The equipment necessary for the examination of the oral cavity includes gauzes to try the mucosa and to pull on certain structures such as the cheeks or the tongue in order to facilitate the observation of anatomical structures. Probe is also necessary to perform dental examinations, especially for the detection of tooth decay. A mouth mirror is also useful to hold certain structures in place in order to visualize the different anatomical elements of the oral cavity. Finally, tweezers can be useful to remove the gauzes and to look for specific signs such as the tweezer sign, to look for fragments of the epithelium that can be easily removed through scraping. This can orientate the diagnosis towards certain autoimmune disorders of the oral mucosa, namely pemphigus and cicatricial pemphigoid. Finally, the examination of the oral cavity ends with the sugar test in order to diagnose potential presence of a xerostomia. Amongst the other fundamental instruments for the examination of the oral cavity, a dental light is absolutely necessary to focus the light onto the patient. Another important element that the therapist must have is a reclining chair so that the patient can be in a lying position. This makes the visualization of the different structures of the oral mucosa easier, except for the examination of the hypopharynx, which requires the patient to be in a sitting position. Before the endobuccal examination, a brief exobuccal examination of the epithelium is performed, sometimes of the scalp and nostrils or external auditory orifices, and of course a palpation of the lymph nodes, which is a fundamental part of the endobuccal examination. Usually the lymph nodes of the anterior cheeks, the cervical lymph nodes and the transverse lymph nodes of the neck are examined. The lymph nodes under the chin can sometimes be examined. In some cases a sensory and motor neurological evaluation is performed. At the exobuccal level, the oral cavity is circumscribed by the cheeks and lips that form musculo-membranous folds. The upper and lower lips join at the labial commissures. These areas are frequently sources of disease that take the form of cracks and can be linked to either candida infections or bacterial infections. Sometimes mechanical traumas can explain the presence of pearlash. The vibrillian edge of the lips, which is the mucosal part, alongside the cutaneous tissue, is formed by multi-stratified keratinized pavement epithelium. We can here see the demarcation between this keratinized epithelium and the non-keratinized epithelium of the lips. Endobuccal examination starts with the examination of the internal aspect of the lips, formed by this non-keratinized pavement epithelium, using a gauze that will dry the mucous membranes. The latter become wet again very quickly due to the presence of numerous accessory salivary glands present in the submucosal layer. These accessory salivary glands are like little nodules that we can feel quite easily if we chew on our lips, as we can see here, for example. Therefore, the presence of numerous accessory salivary glands explains the frequency of these disorders, especially the formation of mucocells secondary to a trauma such as a bitten lip. We can see in the lower part of the lips, at the level of the alveolar labial ridge, presence of a fibrous structure termed the frenum. These freni have no histological impact. Sometimes they are hypertrophic or are inserted in between two teeth, causing a diastema. An exeresis is then performed. This mucosa is highly vascularized, as seen here, due to the extreme thinness of the epithelium. For the upper lip, analogous structures can be observed. Here we see the presence of an anterior frenum that can also cause a diastema, and the presence of numerous accessory salivary glands under the mucosa. Examination of the upper labial mucosa is followed by the examination of the gum. We can observe at the level of the neck of the teeth a collarette of gum termed marginal gum that borders a ridge of roughly 1 mm in depth, forming the subcus. In pathological conditions, this ridge is much deeper, creating a periodontal pocket. The gum collarette is attached to a band of gum which appears whiter, which is the gum that is strongly attached to the bone tissue and protects against gingival recessions. A specific area of the mucosa, located between the teeth, is called interdental papilla. This interdental papilla is constituted by non-keratinized epithelium and has a slightly concave shape, which enhances the accumulation of dental plaque and therefore increases the frequency of periodontal diseases. The attached gum, which has an important protective role, then turns into free mucosa termed alveolar mucosa. In this area of attached gum that is mainly involved in autoimmune bullous disorders of the oral mucosa, especially in cases of cicatricial pemphigoid, and is the most frequently affected area of the oral cavity in this disease. The mandibular gum is composed of the same anatomical elements as the maxillary gum. The endobuccal examination is followed by the examination of the mucosa of the cheek, which has the same histological structure as the lips, a covering mucosa. However, the number of accessory salivary glands is smaller, which explains why diseases are less frequent in this area. An anatomical element that is characteristic of the cheek mucosa is the stenon canal, which is the main canal for the parotid glands. We can see the orifice at the end of the probe. The ostium of the stenon canal is located opposite the teeth number 6 and 7, and by massaging the parotid canal we can observe the quality of the saliva that is secreted at this level, which we observed just now. The quality of the saliva that is secreted at this level is a sign of a potential infection related to parotiditis, which is relatively frequent in these glands. Examination of the oral cavity continues with the examination of the anterior part of the ventral side of the tongue. At the level of the anterior part of the floor of the mouth, on either side of the tongue frenum, we can observe small caruncles corresponding to orifices of the main canal of submaxillary glands known as Wharton's canal. Subangulo-mandibular palpation of the gland can lead to a small burst of saliva that will show the quality and quantity of saliva and the presence of a potential infection. This area of the oral floor is covered by an extremely thin epithelium and can be seen by the numerous blood vessels that can be observed by the transparency. This is also an area where different toxins and carcinogenic agents stagnate and can cause cancer. If the patient is not asked to touch his or her palate with the tongue, it is an area that remains hidden when the mouth is open. The examination continues with the examination of the gum underneath the tongue that has an analogous structure to what we can observe at the vestibular level. Examination of the ventral part of the tongue continues with the protraction of the latter using a swab in order to visualize all the ventral part, often associated with leukoplakia type white lesions due to smoking. Finally, the clinical examination of this area continues by pushing back the tongue using a dental mirror in order to examine the area of the floor of the mouth that forms the alveolar lingual ridge. In the most anterior part, we can often observe salivary gland disorders such as ranula that are similar to mucous cells at the level of the sublingual glands. To examine the dorsal face of the tongue, we ask the patient to pull his or her tongue out. On the dorsal face of the tongue, we can see a papillary system that is highly developed, filiform papillae that are small keratinized white papillae that are important for crushing food against the palate. In some cases, in particular with subural tongue, there is an increase in the number of papillae, and this is associated with excessive desquamation and sometimes accumulation of dental plaque. Between these filiform papillae, we can observe the presence of small fungiform papillae that are small reddish papillae, hypervascularized papillae that contain numerous neck buds. These papillae are not associated with an inflammatory process, which is what the majority of practitioners believe. The papillae that are the most difficult to examine, that often lead to consultations even though their presence is purely physiological, are calciform papillae that we can see here and form the velingule. On the anterior face of the tongue, we can see filiform papillae that are involuted in humans and that contain numerous